I'm Christy Cade with the White Ribbon Alliance.
And I'm Sandy Garcon, Coalition Director of the Self-Care Child-Based Group. We are thrilled to welcome you to the Self-Care Learning and Discovery Series. We are a global coalition dedicated to ensuring everyone practices self-care. We advance self-care advocacy, evidence, practice, and learning to support people meeting their own health goals and to strengthen health systems.
The World Health Organization defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. The series has invited more than 50 organizers from around the world to share what self-care means to them in practice through 16 individual sessions. While each session examines self-care through a unique lens, they are very much connected. We encourage you to participate in as many as possible.
The Discovery Series is open to everyone: advocates and activists, healthcare providers, government officials, program implementers, community members, because all of us should have a vested interest in self-care. We hope you share your own ideas and insights throughout the series and keep the conversation going by becoming a member of the Self-Care Child-Based Group. We'd like to thank the members of the Self-Care Learning and Discovery Series Steering Committee, Advanced Family Planning, JPIGO, PATH, Population Services International, and most of our White Ribbon Alliance. Without you, this learning opportunity would not be possible.
We also want to thank all of the session organizers who have dedicated their time voluntarily to curate this event. We should also say that each of the organizers took on the responsibility of the content in individual sessions, and so they might not necessarily reflect the views of the steering committee. Please take what you learned today and apply it to advancing policies, programs, and practices that enable self-care, universal health coverage, and your own individual health and well-being. Now, without further ado, we turn it over to today's session organizers. Thank you.
Thank you and enjoy.
Welcome everyone to today's session, More Love, Global Lenses on Respectful Care and Self-Care. We're looking forward to an open conversation guided by presentations from a range of panelists, from practitioners, healthcare providers, to women and policymakers. We'll be discussing the intersection of respectful care and self-care, from frameworks to everyday experiences, and then inviting you to share in an open and honest conversation about the systemic challenges women and providers face when trying to care for themselves and others. So first, I'm going to introduce myself, and I invite you all to introduce yourselves in the chat box. So I'm Elizabeth Dawes-Gay, an advocate for social and reproductive justice for women of color. I'm a consultant, a writer, and a social impact entrepreneur. And I'm a co-founder of Black Mamas Matter Alliance, so this topic is very near and dear to my heart. I'm so grateful to be here today as your moderator, and I look forward to an awesome conversation. But before we get started, I'd like to share a few Zoom instructions to make your experience as seamless as possible. Please note that you can select your preferred language for translation by clicking on the globe icon at the bottom of your Zoom screen, which says interpretation, and then picking either English, Spanish, or French. We will have presentations in multiple languages, so if you are an English speaker, please be sure to select English. This meeting is being recorded, and all of the series session recordings will be available on the series platform for you to view at your convenience. Please keep your microphone on mute while you aren't speaking, but if you have a question or you're sharing, please feel free to unmute yourself or use the raise hand function and then unmute. You can also feel free to add questions in the chat box throughout the event, which we'll be monitoring, and we will direct any questions that you have to the speakers at the conclusion of their presentations. If you have any technical questions, please direct those to Nana at TechChange or Nisha Singh, who you can find in the participant panel. So we'll also be exploring some personal topics today using justice and compassion frameworks, and we want to ensure an inclusive and affirming space for everyone involved today. So we ask that you respect everyone's perspectives, experiences, and identities. In this space, we acknowledge the existence of racism, discrimination, and privilege, And we enter here today in a joint effort to combat the way that racism affects people in violent or discriminatory ways. This is also a trans and gender affirming space. So please make sure to honor people's names and pronouns. And we also invite you now to rename yourself to include your pronouns if they aren't already there. Chats and comments will be moderated to ensure that these principles and understandings are respected. So now we're going to take a minute to get to know all of you in the virtual room with a quick exercise. There will be a link dropped into the chat box, and we'd like for you to click through and tell us in 3 to 5 words what comes to mind when you think of humanization in the medical profession. Again, in 3 to 5 words, let us know what comes to mind when you think of humanization in the medical profession. And this prompt is available on the screen right now. Okay, we've got one response that says affirming care, compassionate organizations and systems, listen to me.
No sabemos cómo entrar a esta.
Empathy, understanding, listening, kindness for patient and provider. So please keep sending those in. Got time off and breaks, trust. I see that listening keeps coming in. It's building up as our main word today in our word cloud. Less profit driven, that's interesting. Less pressure. So there's things that we need more of and things that we need less of. I see dignity, smile, support, ending medicalization, fewer interventions, and making sure that people feel seen, heard, and valued. But we'll just take a few more seconds to make sure that everyone can get their responses in. So last call, in 3 to 5 words, what comes to mind when you think of humanization in the medical profession? I see that some folks have entered their responses in the chat, but we're using slido.com to collect these responses. So please make sure to enter your responses there so we can capture them in the official word cloud that we're creating for this meeting. We would love to make sure that those responses are reflected there. So right now I see respect, listening, compassion, empathy, trust, and affirming care as the top priorities when folks are thinking of humanization in the medical profession. And so right now I'm going to introduce our next session, and which is on this very topic of humanization in the medical profession. We're going to hear from experts in respectful care frameworks and from policymakers who have successfully integrated those frameworks into medical trainings for systems change. The second part of this session will include perspectives from women and providers who support self-care and self-advocacy by women who have to navigate these challenging systems. So to get started, I'm going to introduce our first speaker. I'm pleased to introduce Carmen Green, who is the National Vice President of Research and Strategy from the National Birth Equity Collaborative. Carmen's expertise is in applications of reproductive justice and research, policy, and culture change for health equity. And she brings a community-based and sociological perspective to the Birth Equity Collaborative. She has co-created and conducted birth equity assessments for health and hospital systems, analyzed qualitative analysis projects, and synthesized data to illuminate opportunities for improvement. Today, she will be sharing more about the National Birth Equity Collaborative's anti-racist framework and cycles to respectful care approach. So turning it over to Carmen.
Thank you so much, Elizabeth. Good morning, afternoon, evening. It's really a pleasure to be here, and I'm excited to speak with you all today because this is National Birth Equity Collaborative's first presentation of our respectful care work on this global platform. So I really appreciate White Ribbon Alliance for this invitation to the series and to this amazing global network. Next slide, please. So my objectives today are colored by our experience as leaders at National Birth Equity Collaborative. We will always view our personal experiences and approach the data in the US through a racial equity lens, because the data suggests that respectful care is also a racial equity issue. My lens will remain on racism and healthcare systems for the duration of my presentation, as will my responses. So today I'm going to give you an overview of our Respectful Maternity Care Grant Project and experience measure, review the research frameworks and the methodologies behind it, and then I'll briefly share some project updates on how it's going and what we're hoping to learn from this network at White Ribbon Alliance. Next slide, please. Our mission is to create systems to optimize Black maternal and infant health through all the things that we do, including trainings, research, community-centered collaboration, and policy advocacy, so that every Black infant and mother celebrates a healthy first year with their families and in their communities. Next slide, please. The definition here for birth equity was created by our founder and president years ago, Dr. Joya Creer-Perry, and that's to better describe our lens and our goals at NBEC. Birth equity is the assurance of the conditions for optimal births of all people with a willingness to address racial and social inequities in a sustained effort, which puts a lot of responsibility and onus back on systems because systems are changeable. Next slide, please. All right. So as Dr. Creer-Perry was doing that research, the background research to ground our project, she was connected with the White Ribbon Alliance. And you all's platform and network was the support and the thought partnership that we needed to move forward in the US context. And so we learned so much from this charter, Respectful Maternity Care Charter. The next slide will show what we have learned in the domestic context from New York City Department of Health and Mental Hygiene. Please go to the next slide. Thank you. And I just the background as well.
Carmen, I just want to pause really quickly to remind folks to please mute themselves in case when they come on, in case they're not already muted, because there was a little background noise. So if you are not muted, please be sure to mute yourselves, especially during the presentation. Thank you.
All right. Thank you, Elizabeth. I appreciate y'all. All right, so what we've learned in the US context is now like knowing that respectful care is a global push for human rights and for all birthing people across the globe. We wanted to see how it has been talked about in the US. And our only evidence was in New York City. Now they have a lot of energy and innovation there in moving forward on reproductive justice and respectful care. But even there, it's not codified into the system. So Dr. Joya really wanted to take it another step further in our initiative. Next slide, please. All right, so I mentioned before that we're always coming with the lens of racial equity and Black joy and justice. So at NBEC, we always say it's racism and not race that is killing Black mamas, that is causing preventable morbidity and mortality. So we always take notes from our leaders. This is from Dr. Kamara Jones, who listed out these 3 levels of racism that really align with what I'm learning in this sociology doctoral program. Like, it is a pervasive thing that we need a ground understanding of before we can possibly address it in systems. So here, very quickly, you got internalized, personally mediated, and institutional racism that are all interlocking and working together. Next slide, please. And lastly, we are informed by reproductive justice. That's from a human rights framework, from womenism and Black feminism, and always uplifting racial equity. But reproductive justice, as you all know, is a human right to maintain personal bodily autonomy, to have children, to not have children, and parent the children we have in safe and sustainable communities. Next slide. Thank you. So for the next, the second half of this presentation, I'll go over what all we have learned within this grant cycle, what we hope to continue with this work, because the maternal health crisis in the US is worsening. And though we are with the richest and most advanced countries in the world, we are doing a disservice to Black mamas and brown mamas and all mamas, because we have not figured how to systematically improve birth outcomes. So we need a culture of respectful maternity care to change that. We believe there's no quality improvement in any health system without equity first, and that we must trust the Black women. We are excited for the potential of this research and quality improvement project because it's a real opportunity, we believe, to improve maternal health experiences for all by infusing anti-racism into healthcare quality improvement initiatives. So ours is just one of many steps and many initiatives that are now creating this normalized new model of care for medical practice. Next slide, please. So as you all know, the first part of research is an extensive literature review, and we did our homework. So the original studies that were most relevant to us were Birthplace Labs, Mothers on Respect Index, called MORI, and the Maternal Autonomy and Decision-Making, MADAM Index. We also learned from listening to mothers, rounds 1 and 3, which were instrumental to our understanding, and the patient-reported outcome measurement system. So the limitations for these, though, were that their applications and scalability were limited almost from the start. There were no studies at the time when we began that focused on Black women, on American women who identified as Black. And we thought that was key because disrespect is cited mostly for Black women. And also the original studies here lacked shared language and meaning for the most affected populations. So these insights were picked out first by our mentor and research partner, Dr. Karen Scott. Go to the next slide, please. So Dr. Scott is a queen. She is an OBGYN who is now a researcher and reproductive justice warrior. She has another quality improvement initiative called Sacred Birth for birth justice, but she has helped us to get our foundations in our respectful maternity care research methodology before we did data collection. And so what we have learned and continue to learn is that large-scale patient-reported experience data does not give us anything useful for fixing the Black maternal health crisis right now. We learned from her how to take community-based participatory research excuse me, how to take it several steps farther through research justice and cultural humility. She said that cultural transformation deepens the capacity for providers and systems to listen to, understand, and respond to community voices, sharing stories of disrespectful and dismissive care and service gaps. To the next slide, please. Thank you. So to facilitate opportunities for Black mamas to be seen and valued in this process of measure development, these are our original research objectives. So just a quick overview, patient engaged research right now is a major business in the US. The federal government is interested, and there are different projects, but we're seeking investment for Black maternal health. It's a huge shift for US health systems, along with value-based payment in general. Coding and analyzing focus group data from Black mamas informs all of our theoretical frameworks and the development of the actual experience measure, that tangible thing for systems. And so that tangible measure will hold hospitals and systems accountable for how all mamas and birthing people experience care. Next slide, please. And on to the next one. What we learned through our initial analysis and development of this framework is that Black women forfeit their own self-care at times to engage in systems. Providers may feel like they themselves are not cared for, they're run down, they're tired and unsupported, and that impacts their ability to show up in love and genuine care for patients. The concept of love does resonate and why maternity care providers chose the profession in the first place. And birthing people can discern what love is and isn't. They can discern what feels like respect and what is disrespect. We just need that language and the process to improve the skills of providers. So accordingly, this is the cycle to respectful care. I will paste the article that we wrote in the chat, if I can get it right after I finish speaking, but this is published and we're going to continue to publish from this research that we did. But this cycle combines theory, analysis, and experiences of Black mamas across the US. It goes, as you see around there, it flows through the different cycles of racism and informed by like social justice frameworks, originally from Dr. Bobby Harrow. This cycle to respectful care, it flows through how a person can liberate themselves, or how, a maternal health care provider can liberate themselves from their normal modes of care, ones that can automatically be seen or felt as disrespect. It acknowledges that people, when they enter into a new frame of thought, they can wake up, shake off their like disrespectful ways that they may approach care in. And after they enter into this cycle, they can repeat the process several times because there's really no end to pursuing equity. But as I mentioned before, it flows from what we can do individually to what providers can do in their ward, then to what we can do institutionally to knock out racism. Next slide. Thank you. On to opportunities. Move on, please. Quickly, the future opportunities for this experience measure are that we want to learn from all of the countries, the locations that are represented on this call and through White Ribbon Alliance. We know that there are measures being incorporated into quality improvement and systems all over, and it's our job to learn and try to apply to the US context. Then it's scaling, because as much as we do work in individual systems, it's the large scale to affect all Black mamas across the US that we're really looking for. And thirdly, is that we're going to do that by aligning with our other partners. We're now partnered with ACOG, American College of Obstetricians and Gynecologists, Black Mamas Matter Alliance. We're kindred partners with them, and they have greatly helped us in every aspect of this research. And moving on to like large national groups that are over measure development for systems like AHRQ and CAPS. Next slide, please. Thank you, and I'm going to end soon, but onto the challenges, figuring out how to really infuse Black maternal health experiences into systems is absolutely difficult. And I'm learning why it hadn't been done yet. Next slide, please. It hasn't been done yet because there are true barriers. One being hospital and health system leadership buy-in. As much as nurses and staff may want to eliminate racism from their systems, if there isn't one department chair or a board member or someone who is willing to be a champion, it does not materialize on a system level. Capacity and funding is real as well, because when providers are stretched, we can expect them to be a champion of another initiative without outside funding. It seems like the impetus is coming from outside in and not inside out. And our commitment to community-based initiatives, because this is so deeply about the Black community. We have a longer shift to have systems truly care about those marginalized communities and our connection with love. How can we bring that back to the fore for providers who are really helping us build our families here? Next slide. So thank you all so much. Thank you for this opportunity once again. And I mentioned this to our entire White Ribbon Alliance family. And I'm excited to learn perspectives of self-care and respectful maternal care from all of you. Please visit us at birthequity.org, which will be relaunching this week, and our other social media channels. But excited to hear from my colleagues. So thank you very much.
Thank you so much, Carmen, for that wonderful presentation and the foundation for the rest of this conversation. I learned a lot from you. It's been great to see what the National Birth Equity Collaborative is up to in the ways that you're contributing to this culture of respectful care, as you put it. I think that's a fabulous way to think about it, that we're creating culture shifts that will result in individual change that scales up to systems level change. So I'm very glad that you were the one to kick this presentation off and set that foundation for us. So if you have questions for Carmen, please feel free to drop them in the chat. We will get to them after the next two speakers have gone and have a group Q&A session. So please drop them in the chat or make a note of them so we can make sure to get to them in the Q&A. Right now, we're going to move on to our next speaker, who is going to help us expand this conversation. Heather Bissler is the Senior Advisor for Compassion Programs at FACE, the focus area for compassion and ethics with the Task Force for Global Health. Heather has 18 years experience in global health in both development and humanitarian settings. She is passionate about fostering caring cultures and health systems in organizations that prioritize the mental and emotional health of its workers and that provides opportunities to cultivate their self-compassion and resilience. Heather, over to you.
Good morning, and thank you, everyone. Well, thank you, Carmen, for kicking us off. That was a super enlightening and invigorating framework that you shared with all of us. And I love that you use the word love. And I want to pick up on that and what you were saying about really, bringing that back to providers, making them feel loved and helping them, or really creating space in the system to allow that to flourish. So Elizabeth, thank you for the introduction. I also wanted to mention that I'm especially excited to be here today because I get to really bring together two topics about which I'm super passionate, and that's respectful maternity care, compassion, and racial equity. So that's, I guess, 3 topics that are intersecting. In the last 7-8 years of my career, I've been collaborating with the White Ribbon Alliance, as well as the Interagency Working Group for Reproductive Health in Crises, to bring the concept of respectful maternity care to humanitarian settings. Since shifting more into compassion and global health, I've also been looking for ways to kind of help these 2 areas meet. And so this is a really exciting conversation today for that. So in my experience working on RMC issues, I have come to understand, and we at FACE understand, that respectful maternity care, it's really a systems issue, right? And no matter where providers are practicing, frontline providers are part of a larger health system. So issues like respectful care cannot be solely placed on those frontline providers. It's not only their responsibility to fix. In the US, there's a 2021 Kaiser Family Foundation survey of frontline healthcare workers that revealed that medical burnout, and we define burnout as mental and physical exhaustion from chronic workplace stress, it's reached epidemic proportions. It was bad pre-pandemic, and now it has just become overwhelming, with 55% of frontline health workers reporting burnout and 62% reporting some kind of mental health repercussion as a result. Physician suicide rates in this country are double that of the general population. That was even pre-pandemic. And systemic racism, violence against Asians, childcare crises for women in medicine, these have all taken a tremendous toll on the mental and physical health of these minoritized groups during the pandemic. And so now with COVID surging again, medical professionals, that includes midwives and nurses, they're being asked to again, give it all they've got when the burnout and the moral injury already have people running ragged. People cannot continue giving from an empty well. Burned out doctors and nurses can threaten patient safety and the quality of healthcare delivered. And so we have to be thinking about how we can support and sustain frontline providers so they're able to provide high quality, respectful, compassionate care. Next slide, please. And if you can click one more time. Thank you. So at the focus area for compassion and ethics, we understand the goal of global health to be the alleviation of human suffering and the promotion of flourishing on a global scale. And in the words of the WHO Charter, to do this for all peoples. Next slide, please. And one more click. Thank you. FACE has done interviews with hundreds of global health practitioners, and from that, we've learned, we believe it's informed our belief that compassion, which is the desire to alleviate suffering, is really the energy, the fuel that animates global health. And I think this is what Carmen was talking about when she was referring to love, and those in helping professions like nurses, midwives, physicians in the birthing community really connect with that, drive their purpose to be in this sector. Unfortunately, we really see a growing lack of compassion in health systems. The erosion of compassion in healthcare and health services has really created a global crisis, which has been exacerbated by the COVID-19 pandemic. Now, neuroscience teaches us that compassion requires 3 elements: an awareness of suffering, emotional resonance or empathy with those experiencing suffering, and action to alleviate and prevent suffering. And that's really the key, taking action. And so we're really motivated to create and sustain health systems that are characterized by compassion. That requires not only inherent compassionate motivation of individual healthcare and public health workers, but also that organizational commitment to supporting communities of practice and attention to this systematic transformation of health systems. Next slide, please. A growing number of global health practitioners are coming to recognize the centrality of compassion and love for their work, both at the individual level, but also at this collective organizational level. And although, a compassion revolution, as we like to refer to it by, that we know this requires a whole systems approach, and we recognize the dire circumstances that both healthcare workers and public health workers are in right now and the mental health needs of this community. Last year, the Centers for Disease Control and Prevention, CDC, reached out to us with concerns about burnout among their COVID responders. So this is, the federal public health workforce. And so we reached out to our friends at the Compassion Institute, which was founded by Dr. Thupten Jinpa, one of the longtime translators for His Holiness the Dalai Lama, to design a compassion-based course to attend to those needs. Next slide, please. Caring from the Inside Out is an evidence-based peer processing group, and it's adapted from compassion cultivation training that was originally developed at Stanford University by Dr. Jinpa. It's rooted in peer-reviewed evidence on workplace stress and burnout, trauma, team optimization, resilience, self-compassion, and integrates neuroscience and psychology. And we know from this evidence that meaningful connection with colleagues can combat job-related stress, as well as increase motivation and resilience. Moreover, it's moments of collective rest. So not just going home and throwing your feet up on the couch or pouring that glass of wine, but really coming together and creating these moments of collective rest that are critical to metabolize the collective trauma that we're all experiencing as a result of the pandemic, the racial reckoning that we're seeing going on in the US and worldwide. Next slide, please. So in Caring from the Inside Out, we get 20 to 30 individuals, colleagues together. And over 6 weeks, we explore the topics that you see on the screen. And through this process, participants are really able to begin navigating experiences of burnout, learn those skills to support resilience, develop self-care habits that really go beyond kind of the pat things that you might typically hear from HR. No offense to any HR folks on the line, but as opposed to really putting the onus, the burden on the individual to cultivate those self-care modalities outside of work, the CDC created this space within the workday to begin to cultivate these skills. Coming together as a team also begins to cultivate that psychological safety that is so important. We've now offered this to over 400 CDC employees, and evaluation results from our pilot with the first 100 COVID responders shows that 81% felt less burned out at the end of the 6 weeks. 86% felt their mental and emotional well-being improved, and almost 90% felt more connected with their sense of purpose. So this course is not only addressing that workplace burnout and stress, but it's also spilling over and having impacts in people's everyday personal lives. Next slide, please. So we offer this course to CDC, public health workers. Our partner Compassion Institute also offers similar courses specifically for healthcare workers. Now, how does this intersect with racism, or more specifically, dismantling racism? Well, compassion cultivation, which includes not only that individual compassion cultivation, but the compassionate health organization and its health systems design, has not only been shown to improve the quality of care, it has also been found to reduce implicit racial bias among clinical professionals. And currently at FACE, we're actively exploring those pathways from compassion cultivation to anti-racism to really understand what is that pathway there. We understand that it works through this core concept of common humanity that undergirds compassion and compassion cultivation, this idea that although we might not experience the same kinds of suffering, I do know suffering. I may not, as a white woman, a white middle-class woman, understand the suffering of racism that a Black woman experiences, or that experience of going in as a Black birthing person to a healthcare facility and understanding the trauma or racism that might face that person. But I have experienced suffering in my own life. And so by connecting with that suffering, and the flip side of it, connecting with joy, I know joy in my life. I know you, I'm looking at Elizabeth, for example, you've experienced joy in your life, Elizabeth. It might not be the same joy, but we've experienced those emotions. And from that, we can begin to connect on an emotional level. And that's really where we can begin to cultivate this common humanity or empathy that enables us to really connect and empathize with people who may be outside of our typical in group. Additionally, cultivating compassion can reveal to that person who's working on cultivating compassion hidden bias and fuel efforts to root that out and really create belonging, again, amongst people that may be beyond their immediate in-group. And so at FACE, we're thinking about how we can introduce compassion cultivation at that clinical training level. If we work at that pre-service level, we believe it'd be much easier to socialize and build health systems that value compassion and love, instead of this empathic detachment that really characterizes clinical training at the moment. Next slide, please. 10 minutes is such a short time to really adequately discuss all of these topics. But I just wanted to end with a short, 2-minute exercise that is characteristic of something that we might do in caring from the inside out. So I invite you now to listen to the facilitator. She's our lead facilitator at the Compassion Institute, and take a few moments to enjoy some collective rest together. If you can please play the audio now. And thank you, everyone. All right, it looks like our audio doesn't work, which is too bad. Again, that moment of collective rest is so, it's really powerful. But perhaps I can send out the recording to all the participants, and you can be able to enjoy 2 minutes of rest on your own time after this. So thank you very much, everyone, and I look forward to the discussion later.
Thank you so much, Heather. Yes, I certainly encourage everyone to take 2 minutes, 5 minutes, 10 if you can, or longer to have a moment of rest, have a moment to relax and recharge. So far, we've heard about tools and frameworks that can help advance respect, love, and compassion. And again, thank you, Heather, for that wonderful presentation on love and compassion in healthcare and self-care. But the question remains, how can those lessons or tools be translated? And so to share some of the experiences and challenges in doing just that, we're pleased to invite Dr. Dinesh Boswell to speak next. Dr. Dinesh Boswell is an experienced maternal health policy expert in India with over 14 years of experience in the public health domain. He was a joint commissioner on maternal health at the Ministry of Health and Welfare, Family Welfare in the government of India, and developed a renowned reputation in conceptualizing and implementing historic national level programs. To share more on that implementation process, I'll turn it over to Dr. Boswell. Thank you so much.
Thank you, Elizabeth. It was a nice introduction. Greetings from India. And I will just, my talk will focus on basically, what we have done, the journey we have traversed. Then, I will be talking about 2 medical colleges in India, how they have reached the RMC they have implemented. And then something about provider perspective and the way forward, how to go about it. Now, we had started, in 2012. And what we did was that we had, layout design of various health facilities where women deliver. That, for example, we have the, various level of health facilities, means on a 5,000 population, we have sub-center, on a 30,000 population, we have a primary health center. And on a 1 lakh population, we have close to, we have the community health center, and then at the district hospital. So we have, shared with the states. We have, states which work within the umbrella of NHM. And we shared the layout designs, and they started implementing this layout designs. After that, what we did was that in December 2017, we actually launched Lakshya program, which is basically quality improvement in labor room, where RMC was a part of that. And, and subsequently in the December 2018, we rolled out midwifery, which is, basically, we started midwifery first batch, but due to COVID, it had to be stopped, because COVID was there at that time in the 20 when we started this. We also actually basically did shared with people that the labor delivery recovery system, the concept, where we actually shared with the state how to go about it, not using labor table as for delivery purposes. So I am talking about two medical colleges. One is located in the northern India, which is the Jawaharlal Nehru Medical College, which is the Aligarh Muslim University, where 7,500 deliveries per annum is being done. And where how they, in 2 months' time, how they introduced the concept. Earlier, there had an apprehension about, the providers, that how you go about it and how it will be very difficult to, implement RMC because the amount of deliveries we conduct. So they actually, in 2 months' time, they overcome all that. And, basically the challenges they faced were, about, lack of sensitization of about the concept in the, and of course, the amount of deliveries we conduct, and fear of mishap, was also there. And of course, the infrastructure and there was no policy. Then for the other medical colleges I'm talking about is the western area of India, which is, Aurangabad Medical College, where they conduct 20,000 deliveries. So what they did was they had these SOPs where, everybody wants to, when they induct residents and, any new faculty comes in, they actually go through the SOPs, the standard operating procedures. Also, they actually, in the antenatal care itself, they had pictures of women, how to, they can actually opt for various birthing positions if they like. And then they also trained all their staff, including, a lot of people right to the, the frontline workers. Everybody was trained how to give RMC. And of course, they introduced the birth companion. So this was a case study which we had shared with other states also, that so that, many times people have this notion that when you conduct so many deliveries, it's very difficult to, introduce RMC, because, you can imagine that conducting 20,000 deliveries in a year, meaning 1,500 deliveries in a month. So, and later on, I move to, talk about the provider's perspective. One of the NGO by the name Sehat, they have taken out this, book, and I have written the foreword for this book. This is a mistreatment of women in labor rooms, perception of healthcare providers. And this is written by Dr. Durga Varnekar and Sangeeta Rege. This is being compiled by Sehat, Center for Inquiry into Health and Allied Themes, Sehat, Mumbai. So, they had shared what are the providers, thought process. In that, they had this, they had, of course, informed consent is there, but that's not implemented in its true spirit. That's one thing which came out very upfront. Of course, privacy issues are also not taken very seriously by the provider. And of course, bias against multi-para and religious minorities. And of course, they had this concept of that labor room violence is accepted, and they justify as a necessity for better health outcomes. And also they shared that when they, sometimes the women, they displayed uncooperative behavior, they become helpless. And so they opt for this type of behavior. And one of the other factor which they found out was that they are not updated with the guidelines which are latest, which is basically shared with the states. And because India being a large state, it is a matter of time that of course the digital is moving at a very great speed, but still there are areas where still people do not find, and they are not updated. Of course, lack of training, site infrastructure, shortages, and of course, the most important thing is that if somebody acts as a champion in a facility, then this is much more easy implemented, because when we see both in case of Aurangabad Medical College and of course Jawaharlal Nehru Medical College in Aligarh, this is a very it comes up front that when people become champion in the facility itself, it becomes much more easy. Coming to the way forward, I think the way forward is that is community empowerment. There is a lot of asymmetry of information which is there, and if you brief you and continuously actually basically empower the community to demand services which are basically our respectful maternity care is there, compassionate care is provided, they are going to get it. Of course, one of the area which we have not touched is about the self-care, which I think is a very, very important concept, which I think when we talked about that, there are a lot of people now eager to join hands and take up this, because in times of COVID, I think this is all the more very necessary now, that self-care care concept should be taken up on a large scale, and so that share with the people, so that they at least they can do self-care which are in their hands. And so that's very, very important. So I now conclude, and if there are any questions, I will be happy to answer them. Thank you.
Thank you so much, Dr. Boswell, for those comments, for highlighting some of the challenges to implementation. I was struck by the number of deliveries that are happening in one location, and how that in itself could influence provider experience, the women's experience, right? Just because of the sheer number of folks, and people have limited time and resources. So I thank you for that. And I want to now spend our next few minutes with questions for all of the presenters, right? I'm sure you all have many things that have been on your mind that came up for you through these wonderful presentations. So please feel free to come off mute if you want to ask a question. I see one in the box now, so I'll just ask it for Dr. Boswell. Could you explain the birth companion component that you incorporated at the facility and what results you saw from that?
So birth companion was implemented, and after we were ourselves convinced that birth companion is a very important concept. It influences the entire birthing process. So we actually from the national level we started, and one of the state in India, which is in southern state, had implemented that birth companion for I think 3 or 5 years. So we took up that, and we circulated the guidelines what can be done. So many times the birth companion concept is actually taken by the provider as an intrusion. We said that you can if you train them well, they can be an asset to you. And also many times what happens is that in Indian context, the babies get stolen, and that's another thing which and they will take care of the mother when they are in basically in that condition where they require touch, where they require, a lot of support from the close person. And, we started it, and I am happy to say that, a lot of facilities came forward and they started implementing it. Of course, challenges are always there, but then, it has to be started somewhere. When people start, they find it, useful, and then that's how, it increases.
Thank you so much. Are there any other questions for our presenters? I saw a lot of gratitude coming in the chat. Folks, really love the presentations, are learning a lot from you all. Want to take a few more moments for any questions that come up. Kimberly has raised her hand. Feel free to come off mute. Yeah.
Sure, happy to. I was typing and I realized it's probably just easier for me to ask my question. So this is to Heather. And first, I just want to say that I thought it was really interesting and exciting that the evidence-based peer, discussion group happened during the actual workday, because I can imagine that for many health providers, their responsibilities don't stop when their shift ends, when they get home and they have family, they may have others to take care of. And, I'm just wondering, that it sounds like that model is working in the US, but did you encounter any resistance to incorporating that type of learning and exchange during the workday? And what lessons or insights would you have for others who are working in other countries and contexts where already time is so scarce and resources are so scarce to take care of patients and people seeking care in the first place? But again, thank you so much. And I'm really excited to learn more about your work. Over.
Thanks so much for your interest, Kimberly. Resistance, no. And again, we piloted this, or we're implementing it with CDC. So it's the public health workforce versus clinical staff. So there may be differences in how you engineer this or work it into the workday if you're actually working in a clinic system. That being said, it was really CDC leadership that reached out to us. And so this was an entirely leadership-led initiative. And because of that, that's why there was space created within the workday. They championed it. They really encouraged their staff. This was one of the center directors. And currently we have, the Office of Work-Life Wellness, which supports, employee care initiatives across the entire agency that is implementing, and we're working with us to offer this to all responders and non-responders. So because it's been championed and promoted at such a high level, we didn't have pushback in terms of incorporating this into the workday. In fact, in some of our recent cohorts, leadership actually, and this is one lesson to your question, a lesson learned, that it's really helpful to have a unique leadership cohort. Apologies for that background. To separate them out, because although seeing the leadership really champion the implementation of this initiative, it is difficult for people to be completely transparent if they know that their boss or their boss's boss is in the same group with them. And so carving out that space to have a separate leadership cohort was important. What I was saying earlier is that leadership cohort actually used a standing meeting that they previously had for other things to be able to use it for the time on caring from the inside out. I'm going to cut my response short because I think my mom is cooking eggs and is setting the house on fire. I apologize.
Thank you, Heather. No problem. We understand, things happen when we're working remotely and working from home. if there's any last burning comments, questions from folks, and also panelists, if there's one thing you want to share that you didn't get to share during your presentation, feel free to share that now before we move on to the next session.
I just want to thank everybody again for the opportunity and the connections that we're able to make through the chat. So please reach out for more information, and I'll be reaching out as well.
Awesome. Yeah, great reminder. Feel free to direct message folks that you want to connect with, that you have questions for, that you want to follow up with, in case there's not time here, and you can do that later. Thank you again. Thank you so much to all of our speakers for their presentations, for discussing the changes that we can make to medical training to humanize the profession, and things that we can do to integrate respectful care into the health system. We certainly saw some of the same things from our collective word cloud that, at the beginning when we started, that came up in your presentations: respect, trust, empathy, listening, those kinds of things that need to show up through systemic change. But until those systems and structural issues are addressed, women are still experiencing challenges to accessing respectful care. So what can women do in the meantime, and how have community health providers helped bridge the gap? That's the next question that we're going to be exploring. But first, we want to hear from you with another poll. So please take a moment now to respond to the questions. What does respectful care mean to you? And how do you practice self-care? So the poll is available at slido.com. You can click the link in the chat. Hopefully someone has dropped it, or it's coming up shortly. How do you practice self-care? That's our first question. So we'll stick with that one. I think there are two questions that we might be doing separately. So and we have our first two responses in. People are practicing self-care by pausing, taking breaks and resting, and prioritizing what they're working on. Physical movement and exercise has also popped up as a form of self-care. Resting, getting outside. Yes, I love getting outside and getting sunshine and fresh air. Supporting people in need of care as a form of self-care. Community care is absolutely a form of self-care. Taking a vacation, time alone, long baths, connecting with other people, connecting with yourself through journaling. Checking in, pausing and checking in, monitoring, checking in on where you are, checking in on your progress, getting outside, spending time with pets. Hobbies, I see some comments in the chat as well. Setting boundaries. Absolutely, boundaries around personal and professional, around work and family time. especially these days, the lines are so blurry. Loving yourself. Okay, so we have responses on how you practice self-care. Nisha, do you want to provide a little direction on how folks can access the other question? Because I think that one would be interesting to answer, what respectful care means to you.
Yeah, so there's a way to, once you click through the link, if you scroll down to event number 15, there's Slido 1, Slido 2, Slido 3. Yeah, if you're not able to answer that question using the link provided, you can answer it in the chat box and we can record it and upload it later. But yeah, I would definitely love to hear from everyone. Not just how you practice self-care, but what does respectful care really mean to you as well as we enter this discussion?
Is there a way to show that on this screen share, that question? Okay, let's take 20 more seconds in the chat to think about what respectful care means to us, and drop those comments in the chat if we can before we introduce our next panel. Okay, thank you so much, everyone. We are going to move on. So in this section, we will hear from community health providers, community leaders, and from women who face intersecting forms of discrimination when they attempt to access respectful care. Self-care and self-advocacy is often a necessity. And then we want to hear from you in breakout discussions where you can discuss your own perspectives, solutions, and connect with one another over shared experiences. But first, we're going to hear from Nicole Jean-Baptiste. Nicole is a mother of two, a full spectrum community-based doula, lactation counselor, yoga instructor, and oral historian. Of Southern American and Caribbean ancestry and based in the Bronx, New York, she strives to center the borough and the Black experience in the birth and social justice activism that she does. Nicole is the founder of Say Birthing Freedom and co-founder of the Bronx Rebirth and Progress Collective. So today she's going to share some examples of Black and Brown community-led and centered approaches to promoting and initiating self-care before, during, and after childbirth. She will touch on grassroots efforts of Black birth workers to meet the basic needs of individuals hit hardest by the pandemic. So Nicole, please take it away when you're ready.
Thank you so much. Greetings, everyone, and a special thank you to the White Ribbon Alliance for the invitation to share with you all today on this global platform. And Elizabeth, thank you for the introduction. I'm so appreciative of your work and that of Black Mamas Matter Alliance. Also, such important presentations today. Thank you to all of the presenters. I really am already very full. So today I've decided to use my time with you all to share how and why, in my view, investment in and support of doula services is one way to promote self-care for people before, during, and after childbirth. When I was contacted about presenting today, the prompt that was shared was, as Elizabeth mentioned not too long ago, what can women and providers do until the structural systemic issues in health systems which hinder self-care and respectful care are changed? So I'd say for anyone seeking out care, regardless of whether it's during pregnancy or not, the best place to start is to secure a solid care team, which should be comprised of caring folks who are also culturally responsive, as well as supportive of your care goals and preferences. In terms of pregnancy and birth, for Black and Brown birthing people, this may mean hiring a provider who is also Black, Indigenous, or a person of color. And for folks especially triggered by the potential for medical interventions that may be avoidable, seeking out the care of a midwife. This also means working with a doula. I get asked all the time, even, we're in 2021, like, what is a doula? Exactly what do they do? So I really want to start there and delve relatively deeply into that. So I'll jump right in. What is the inherently patient-centered role of a doula? So a doula is a birth companion, as explained by Dr. Boswell earlier, or a trained birth assistant who provides physical, emotional, informational, and advocacy support to individuals before, during, and after childbirth. In hospital settings, doulas are not to be considered staff members. Rather, they are an additional member of the laboring person's support team, requested and appointed specifically, especially by that person. They perform no medical tasks. Doulas provide continuous labor support to pregnant individuals, which includes physical touch, emotional support, non-medical information sharing, and advocacy. Some examples of physical touch commonly used by doulas are massage. We do hip squeezes. Hip squeezes provide counter pressure to the laboring person's body. And we also assist people getting into and out of various positions with the ultimate goal of reducing, if not eliminating, discomfort and encouraging labor to progress steadily. Some examples of emotional support offered by doulas are encouraging words, which in my view very much feel like self-care, just being offered by the person who you've trusted to support you in this way. And what these sound like are, you are doing a great job, or the surges, also known as contractions that you are experiencing, are perfectly normal, and they are helping you to bring you closer to meeting and holding your baby. Sometimes a simple "you got this" is exactly what a laboring person on the brink of maybe even panic during labor needs to hear to recenter them and relax. We've heard a lot about relaxation and recentering and all of the ways that people care for themselves. This is even more important during labor. And this is the care that doulas seek to deliver. And I'm pretty sure that one thing all birth professionals can agree on is that relaxation during labor, as I've said, is critical to progress and safety. Everyone, we can all do our part as birth professionals to help birthing people maintain or achieve this. An example of informational support that a doula provides is explaining to their client in basic, everyday terms, the utility, the benefits, the risk of common, sometimes helpful, and sometimes necessary hospital interventions. In my practice, one of the things I do and I found helpful is breaking down these terms so that they're easily understood by sharing a bit about a past client's experience, obviously without including any personalized or confidential information, right? And so this is a way of reminding folks that there are tools that they can use. There are experiences that they can glean from that have happened to other people that can support them in their specific instance. It humanizes the experience. It makes it feel not as foreign, not as scary. One of these tools that I often use with folks is an acronym, BRAIN, or BRAIN. And what that means is that in most situations, there are benefits, risks, alternatives, intuitive driven courses of action, and the possibility of doing nothing, or make it known that they need more time to decide on how they'd like to move forward. And finally, doulas offer support in the form of advocacy when necessary. The power dynamic at play during birth, usually in hospital settings here in the United States, where you have a laboring person in a highly vulnerable state and a team of medical professionals, too often create situations where this person's requests for time, for privacy, among other things, are disregarded. This warrants a respectful assertion of our clients' legal rights to informed consent and their human rights to a safe, dignified birthing experience. The benefits of doula care are supported by consistent, high-quality research. The most recent Cochrane review from 2017 analyzed data from 26 individual studies involving more than 15,000 women. The review's findings include the following benefits to continuous labor support in the form of doula care and no known harms from said care. And they are a 39% reduction in the likelihood of cesarean births, a 15% greater likelihood of a spontaneous vaginal birth, a 10% reduction in the use of pain medications, shorter labor by an average of 41 minutes, and a 31% reduction in reporting a negative birth experience. Okay, so now I'd like to say a little bit about how doulas and healthcare providers can work together. One of the first things that I think is fairly basic is to strengthen the bond prenatally. Ensure that doulas can be present at prenatal visits. During COVID times, a lot of this has turned to telehealth, and I've had the privilege of joining in on some telehealth sessions with my clients at their requests. And I found that to be a really great way to build that relationship amongst the team, because this is a birth team, right? We're working for our client on that same team. A 2013 study published in the Journal of Perinatal Education on the impact of doulas on healthy birth outcomes concluded that the inclusion of doulas in the prenatal period at a point when behavioral changes can most impact birth outcomes is most effective. Therefore, if obstetricians and other birthing professionals could include a plan of doula support in the prenatal period, adverse birth outcomes associated with the lack of social support or for birthing people in general can be greatly reduced. This would benefit the birthing people and babies, medical practitioners, hospitals, and the greater community in reducing the financial and personal costs of adverse birth outcomes. During labor, healthcare providers and doulas should view themselves as teammates, as I've said, with a shared objective for supporting pregnant people to achieve safe, satisfying births where the baby and parent remain healthy and respected. What we know specifically in the United States is that Black birthing people overwhelmingly report feeling disrespected and not listened to by their medical providers during labor, resulting in negative, traumatic even birthing experiences. Respect looks like providers listening to their patients. We are telling you, based on countless experiences, that it requires a greater depth of awareness of doing so when your patients are Black and brown. Respect for one's patient includes acknowledgement of and an earnest attempt at collaboration with their chosen doula, who is their hired support professional, or sometimes their chosen support professional. A lot of times when we hear the term hired, we think of like some sort of financial transaction. And I'm speaking as a community-based doula, wherein there are many, many instances where I support folks where there is no financial transaction made between myself and the client, right? So this, just consider that this professional is chosen for and by the patient, and that means so much. Also providing follow-up care in the immediate days and weeks following delivery, including information about postpartum doula services, in addition to counseling and infant feeding resources. I'd also say, one area that could be improved is supporting alternative birthing options, including the use of midwives. Honor the physiologic process of birth more. Integrate comprehensive and anti-racist training for all staff, including doctors and nurses, as well as in the curricula for all medical professionals. And to close, I'd like to encourage providers of Black, indigenous and people of color patients to explore the existing community support systems to which your patients turn when in and out of crisis. These organizations are trusted by your patients for good reason. There are several images that often replay in my mind when I think of this work, this birth justice work, so deeply rooted in and driven by communities' needs. One of these images is a recently created mural of a Black birthing person who died during childbirth last year. And I visit this mural often. It's in Brooklyn, New York, not too far from where I live in the Bronx, New York. This mural is of someone whose name is Chiapas, Washington. And even closer to my own home is where another Black mother died, a preventable death during birth in the same year, last year. Her name is Amber Rose Isaac, and she's of the Bronx, New York. In response to the death of Amber Isaac, I joined forces with two other comrades in birth work and justice, Carmen Mojica, who's a midwife, and Evelyn Alvarez, who is a longtime community birth worker. And what we did was we created a part of the system that for so long has failed us. And you know, when we got together during the height of COVID last year, we weren't completely sure on exactly how we'd show up for community. We asked though, and community responded with a resounding cry for basic material resources. And so in less than 6 months, we raised over $100,000 in grassroots funding and donations to support our community. And these were primarily donations of diapers, formula, and wipes. And I really make it a point to mention this because one of the things we say in our work is that all health is maternal health, right? So I spent a lot of time just now talking about what doulas do during birth in particular. However, this expands, you know, this is the full spectrum of life, really. You know, in order to give care to your children, in order to parent, in order to be well, your needs need to be met as well. And so this is where we met community, and to do so, we raised over $100,000 in grassroots funding. We sourced those donations. We were delivering them to people. We were doing this and continue to do this without any sustained financial support and as part-time volunteer work. Despite this, despite some of those inconsistencies in sustainability measures, one of the things we were able to do was make over 700 contacts with Black birthing people, providing material resources, as I've said, and we've begun to build out a network of full spectrum doulas to care for pregnant people and families in need. We've also started mentoring, training, and connecting pregnant bronchites, doulas, and midwives. This critical connection is life-saving. My co-founders and I have a track record of supporting healthy births by meeting the complete needs of the birthing person. And with that, I will close. I thank you all for your attention, your commitment, and for the work that you do.
Thank you so much, Nicole, for those wonderful, insightful comments. And congratulations on mobilizing those resources to support the folks in your community. That's fantastic. Thank you for explaining what a doula does and how the birth team can come together, as well as engage community-based resources to support birthing people. I just want to remind folks that we will take questions as a group. So after the next two speakers go, we'll have questions for Nicole and Ophelia and Dora. So please start posting your questions in the chat, or you can hold them for the Q&A. Just a reminder to go ahead and select your language. If you need interpretation, please do so using the interpretation button that is down at the bottom of your Zoom screen. So up next, we'll have Ophelia Perez Ruiz and Dora Lucia Mendez Alfonso, who will share their experience providing traditional midwifery care to indigenous women and rural communities in Chiapas, Mexico. All righty, so please, ladies, take it away.
Muy buenos días, tardes y noches a todas. Pues Nosotros somos el movimiento de parteras de Chiapas, Nichishim, Flor de Maíz. Estamos muy agradecidos con la Alianza de Listón Blanco por habernos permitido participar dentro de este conversatorio. Vamos a hacer una breve introducción sobre qué es nuestro movimiento. Para empezar, queremos decirles que somos más de 650 parteras y parteros, junto con aprendices de más de 33 municipios indígenas, rurales, urbanos, mestizos de Chiapas, unidos desde el 2017. Y todo esto ante los obstáculos que hemos visto para ejercer la partería tradicional, pues nos unimos para impulsarla y defenderla. Somos un movimiento autónomo e independiente, no asociado a ningún partido político o el gobierno. Abierto para todas las parteras o aprendices que quieran luchar por sus derechos. Entre todas hablamos diversos idiomas, como somos Chol, Tojolabal, Cental, Tzotzil y el español. Siguiente. El movimiento tiene 36 representantes encargadas de cada grupo a nivel comunitario y municipal. Hasta el momento tenemos 7 voceras con funciones organizativas de gestión comunitarias y hacemos vinculación y vocería, fortaleciendo el funcionamiento interno y capacitación a nivel estatal, nacional e internacional del movimiento. Siguiente. Los objetivos y exigencias del movimiento son defender e impulsar la partería tradicional, derecho a tener reconocimiento y dignificación de la partería tradicional, el libre ejercicio de la partería, o sea, que no nos prohíban atender los partos a las mujeres, reconocimiento del derecho de las mujeres a decidir dónde y con quién parir, servicios de salud accesibles, de calidad y respetuosa con nuestras comunidades, derecho a la protección, conservación y transmisión de los conocimientos ancestrales de la partería y medicina tradicional. ¿Qué sigue? Este es un mapa donde tenemos ubicadas a las parteras que están dentro del movimiento. Como podemos ver, pues aún nos falta mucho territorio chiapaneco que recorrer, que agregar al movimiento y esperemos poco a poco irlas incluyendo dentro de nuestro movimiento. Siguiente. Las barreras de las mujeres para una buena atención, pues por el momento la desigualdad de género hace que las mujeres en sus propias comunidades tengan poca capacidad para decidir sobre sus cuerpos y no cuentan con conocimiento sobre sus derechos sexuales y reproductivos maternos, ya que en algunos pueblos, pues el machismo es bastante y no les dejan a las mujeres que conozcan su cuerpo o les dicen que eso es malo. La experiencia de las mujeres indígenas en los servicios de salud está caracterizada por el maltrato, las regañan, las menosprecian, no les hablan en el idioma, la atención es inadecuada y es pertinente y no tiene pertinencia cultural. Es decir, que los médicos, pues, básicamente cuando una mujer habla de otro idioma, pues no saben ni siquiera qué es lo que tiene la mujer, ya que no hay traductores dentro de los hospitales para que ellas puedan conocer a detalle qué es lo que el procedimiento médico que les van a realizar, ni para expresarse ellas mismas qué es lo que tienen. Además que también dentro de los hospitales no hay equipo suficiente, ni medicamentos, ni personal médico. Muchas mujeres indígenas tienen la mala experiencia de que les manden de un hospital a otro incluso aunque vayan con una emergencia obstétrica. La violencia obstétrica es algo que enfrentan muchas mujeres en México y en Chiapas. Y esto pasa muy a menudo por la misma falta de conocimiento en la barrera idiomática, ya que no hay quien les traduzca a la mujer o a los familiares cómo van. Y muchas veces también la partera no habla el español y es muy difícil que se pueda comunicar con los médicos para decirle cómo está la mujer y en qué condiciones está. La que sigue, por favor. Las barreras que encontramos como trabajo, como parteras, son que no somos respetadas en los centros de salud, pero sí son utilizadas al servicio del personal de salud. Les piden que lleven embarazadas, que limpien la clínica, que hagan recorridos por barrio o por comunidad buscando a las embarazadas para que luego las manden a la unidad de salud. Que eso pues es trabajo, digamos, de personal de salud que está dentro de las clínicas. A las familias que atendemos les ponen trabas para dar los documentos oficiales del nacimiento cuando son atendidas por nosotras las parteras. En general no recibimos ningún apoyo ni económico ni en materiales, pero sin la atención de las parteras los hospitales se saturarían mucho más de lo que ya están. Se ha criminalizado nuestro trabajo, acusándonos de ser las causantes de la muerte materna y neonatal, y en algunos casos se ha llegado a prohibir que atendemos partos. De hecho, aunque somos muchas que resistimos, en casi todo México ha desaparecido la partería tradicional. Le doy la palabra a Ofelia.
Sí, pues, ¿qué hacen las mujeres y
Siguiente diapositiva.
Siguiente, por favor. ¿Qué hacen las mujeres y los proveedores hasta que se cambien las cuestiones estructurales y sistémicas de los sistemas de salud que obstaculizan el autocuidado y la atención respetuosa? Pues retomando un poquito lo que acaban de presentar las compañeras de otros países, pues la primera opción para muchas mujeres en Chiapas es la atención con parteras. Es una opción cercana, más respetuoso, que también hablan directamente su idioma y con sus claves culturales. Las parteras atendemos partos, pero también nos ocupamos de muchos otros aspectos de la salud de las mujeres. Con esto de la pandemia que estamos viviendo, pues también la mayoría de las parteras hemos seguido atendiendo por compromiso hacia las mujeres, a pesar del miedo al contagio. En unos meses en que los escasos servicios de salud de Chiapas se concentraron en atender con COVID, las parteras también atendemos a muchas mujeres y evitamos que la muerte materna se eleva. Esta experiencia ha mostrado la importancia de que los proveedores comunitarias de salud estén organizados, fortalecidos y vinculados para lograr atender de manera oportuna a las mujeres. Las parteras del movimiento tratamos de estar en comunicación directa con los servicios de salud para los casos de emergencia obstétrica, aunque muchas veces tenemos que hacer muchos esfuerzos para que las mujeres quieran ir al hospital, ya que la asocian con experiencias de maltrato o inatención. Hemos creado vínculos que nos permiten avisar a los hospitales para que no haya rechazo, como ha ocurrido en numerosas ocasiones. La que sigue, por favor. Perdón, como movimiento también, es antes de esta presentación, como movimiento también tratamos de que las mujeres conozcan sus derechos que puedan exigir una buena atención oportuna y respetuoso. Esto es muy importante para ir empujando cambios en el sistema de salud. Les damos pláticas a las mujeres que atendemos sobre sus derechos e información para su autocuidado. Estamos creando también unos spots de radio y haciendo alianzas con otras organizaciones para llevar estos mensajes a más mujeres. Como parteras tradicionales organizadas, tratamos de mejorar cada día nuestro trabajo. No nos oponemos a recibir talleres de capacitación o intercambios de experiencia, pero queremos que se hagan desde el respeto a nuestros conocimientos y saberes. Incluso de forma interna, también reflexionamos sobre la necesidad de mejorar nuestro trato hacia las mujeres para no repliquemos la forma inconsciente las violencias interiorizadas. Como organización, luchamos para que el sistema cambie. Desde que iniciamos, hacemos incidencia para impulsar cambios en el sistema. Bueno, más bien para que no haya más discriminación y maltrato desde instituciones de salud, que eso también vaya disminuyendo y haya mejor servicio de calidad para todas las mujeres o para toda la población. También, ¿qué implica realmente el cambio de poder en el sistema sanitario? Que también eso, que haya una interculturalidad y humanización debe ser pilar de la atención de un nuevo sistema de salud, que también que se introduzca desde las universidades, porque muchas veces no hay eso, ¿no? Y entonces eso hace que también no esté completo la información que llevan para que puedan atender la salud de los pueblos. Debe haber cambio desde debe haber un cambio también desde poder en el sistema. Implica que haya tomas de decisiones más democráticas, con inclusión de otros actores. Las parteras deben de estar presentadas en ese toma de decisiones sobre la salud materna, que también es muy importante, porque las parteras siempre van a estar en las comunidades atendiendo la salud de las mujeres. Otro que también implica un presupuesto para las parteras, que no lo hay, ¿no? Como habían comentado también en otras presentaciones, que las parteras están trabajando prácticamente sin recibir ni un sueldo. Implica también trabajar mucho más con las comunidades rurales, indígenas, acerca de cómo quieren los servicios y las infraestructuras de salud, porque también igual no está apta para la atención de las mujeres. Entonces, donde también pueden llegar a tener temor y miedo para irse a atenderse al hospital. Y como decían unas, que también o el doctor de la India que acaba de dar su presentación, que lo incluyen a su pareja o estar con su esposa durante el trabajo de parto, porque sabemos que es importante la producción de hormona de amor para que siga continuando con el trabajo de parto dentro del hospital, para que no tengan más miedo y que no obstaculice el avance del trabajo de parto. La otra también, para transferir poder, las instituciones de salud tienen que cambiar su percepción sobre la que sigue, por favor. Para transferir poder, las instituciones de salud tienen que cambiar su percepción sobre los otros sistemas de salud. En este caso, el de salud indígena, para partir de ahí, tener relaciones horizontales con los proveedores de salud comunitaria, para que no haya un poder diferente hacia las mujeres o hacia las parteras, porque muchas veces son, ¿cómo se dice? Porque las regañan, las discriminan, que no haya esa discriminación, entonces que la relación sea horizontal. Estas relaciones entre distintos proveedores deben de estar basadas en el respeto y reconocimiento de forma que permitan una coordinación afectiva para la atención de la salud de las mujeres, porque ese es nuestro principal objetivo. Los proveedores de salud comunitaria como parteras tienen que estar en un proceso de organización y revaloración de su propio papel y actuación como tratamos de impulsar desde el movimiento, para situarnos en esa posición horizontal y desde allí coordinarnos con las instituciones de salud. La que sigue, por favor. La que sigue. Nuestro logro como movimiento, que también para nosotros es muy importante, es que se ha impulsado una agenda nacional donde participan parteras y organizaciones de 10 estados de la República Mexicana. Tenemos 3 trabajos de mesas, como hacer denuncia de violaciones a los derechos de las parteras, hacer campañas de sensibilizaciones sobre el derecho a atender de las parteras y de las mujeres a decidir dónde y con quién atenderse. También tenemos una mesa sobre solucionar a los problemas de obtener certificados de nacimiento. Se posiciona también la constancia de alumbramiento propio del movimiento para no tener siempre ese problema de tener una identidad de las niñas y niños atendidos por las parteras. La que sigue, por favor. Next. La que sigue. En Chiapas también los pueblos indígenas conservan su organización social, sus propios sistemas de salud y sus conocimientos, con sus propios agentes de salud, y como parteras también formamos parte de ella. Nuestro compromiso con las comunidades es atender y sostener la vida. En Chiapas, 1 de cada 3 partos es atendido por parteras tradicionales. Las mujeres prefieren atenderse sus partos con nosotras como partera. Las estadísticas oficiales dicen que en Chiapas habremos alrededor de 5,000 parteras tradicionales, pero yo pienso que somos mucho más. También en Chiapas los pueblos indígenas conservan, perdón, aquí repetí. Pues también la mayoría de las parteras nos hemos organizado por lo mismo que hemos estado también sin el reconocimiento, como acaba de mencionar Lucy. Entonces, pues aquí vamos a seguir manteniéndonos y para seguir luchando y posicionando lo que es la partería, porque tenemos un objetivo que cumplir, que es seguir atendiendo la salud de las mujeres y para también igual prevenir la mortalidad materna. La que sigue, por favor. Bueno, pues también igual, pues les agradezco mucho también la invitación que nos ha hecho Alianza del Listón Blanco, y también el apoyo que nos está dando ahorita Giselle, por la interpretación, porque ahorita no entendemos tampoco el inglés, y muchísimas gracias por esta invitación.
Antes de retirarnos, pues nos gustaría invitarlos que pues visiten nuestra página web, nisishim.org.mx, y pues tenemos allí el correo electrónico también, parterasnisishim@gmail.org, y nuestro número de teléfono, que es agregando el prefijo 52, que es de México, 967-270420. Les agradecemos mucho. Gracias a Listón Blanco por darnos este privilegio de estar en el conversatorio.
Muchas gracias. Thank you so much for the presentation. I heard, a lot about the need to shift power, the role of midwives, and when you were talking about the experiences of indigenous women, a lot of people were commenting in the chat that they also saw how cultural and language barriers affected people in different countries. So this is a global problem, and I thank you for highlighting that. So I just want to remind people that there is translation available using the interpretation feature down below. You know, hopefully you were able to hear and take away from this presentation because it had some very, very important and insightful information. So we're gonna have one question from the chat. We are running a little bit behind on time, but someone in the chat commented, "I'm a postpartum doula and have so much respect and admiration for birth doulas and birth workers. I'm curious, in your opinion, what are the biggest challenges that doulas, and I would add midwives, experience from care providers in hospitals? I often hear from birth workers that they don't feel supported by providers and that this tension that's created will negatively affect the birthing person." So we're just going to take that one question for both Nicole and for Dora and Ophelia.
Thank
Nicole,
you.
go first. Yeah.
Yeah, I'll go first. Thanks for that question, Molly. I would say, I would agree. Yeah, one of the biggest roadblocks that doulas experience is a lack of support and recognition of our role. I think this is largely rooted in gaps in information and understanding of what we do. Many times doulas will walk into labor and delivery rooms to support clients, and we're met with an adversarial atmosphere because there's this assumption on the part of medical staff that we are they're solely to challenge them, and this is not the case. We're there to support our clients in achieving their birth goals safely. To do what we can to prevent birth trauma, essentially. And I think that there are fixes to this, right? So learning that's why I do spend time sharing what it is that a doula does, how we show up in the space, because that misconception can really be disadvantageous. Thank you for that question.
Thank you. Dora, Ophelia, any response to the question?
Sí, nosotros, cómo se vincula con la institución, pues ha sido un poquito más difícil la relación con ellos o la vinculación, porque siempre nos ha dejado muy afuera del sistema, pero tampoco queremos que seamos parte del sistema. Lo único que queremos es que la vinculación, en cuanto haya alguna complicación, que facilita la aceptación y la atención en los hospitales cuando lo trasladamos. Y otro también es de que que nos permitan seguir ejerciendo la partería, porque es los problemas que hemos encontrado, como acabamos de mencionar, de que nos han obstaculizado seguir atendiendo a las mujeres durante el embarazo, parto y después del parto. Entonces, eso es lo que seguimos exigiendo, que esa es una vinculación que nosotros queremos como parteras.
Okay, thank you so much. Up next, we have Bhavana, the Director of Information Technology and Communication at Help Life in India. She will share more about her work and personal experiences helping girls and women with disabilities and their barriers in accessing respectful care, as well as the role of self-care. So Bhavana, please take it away when you're ready.
Yeah, good morning, everyone. It is a challenge for me to speak in English, but I will try. Thank you very much for this opportunity to speak on respectful care and self-care for girls with disability. I want to start by saying that there is no respectful care, but care of sympathy. Next slide, please. We grow up listening to the phrase Bechari, that means helpless. We also start believing that we are helpless because lack of mobility. Our life has no value in the society. Firstly, being in poor family, and secondly, as a girl, is a curse. In addition to being a girl from poor family, there is a disability that adds to our suffering. Life is struggle at every step, and the goal is just to survive at other sympathy. Next slide, please. No matter how many people are around us, but we are always alone. No one plays with us. On the table, we have a place. Even then, our voice is not heard. Next slide, please. There is only care of sympathy. Next slide. First time we get the calipers after waiting for long. Using the same calipers for 4 to 5 years give us lot of pain and pelvic deformities. Operation in a free camps. Many a times operation is unsuccessful. Doctor don't pay attention because there is no follow-up. So where is the respect? Next slide, please. In this slide, I want to show the basic service is not easy for us. Disability certificate is essential to get access to the government schemes. The process of getting this certificate in itself is painful enough. Something that should be posted to our home after filling in the online forms take months to arrive. Please look at the flowchart that show the time spent only to submit an application. In this process, the girl need to use the restroom that does not exist. In my own experience, in my own case, I had to pay 150 to a nearby lodge to use the restroom. I have 90% disability, confronted by the bad looks of the men around that place. So where is the respect? Next slide, please. In this pictogram, show the process that took 10 hours for the whole process and displayed that no certificate was received on the same day. Next slide, please. After 8 days, I went through the same process again and spent 10 hours to get the certificate. Next slide. Now comes the sexual harassment and abuse. No one talks about it for disabled girls. Young girls with disability in the hostel for the sake of studies are exploited, and there is a lot of sexual harassment and abuse. The girls do tolerate as they want to complete their studies. They have no voice and strength to fight the society. That is the male dominated and sexual advances are seen as normal. This is because of complete disrespect for the girls with disability for a number of culture and economic reasons. Marrying young girls with disability to old men who are divorced or even having another wife is a common practice in our culture. That is mainly because of poverty, as no young men want to get married to us. Men to get normal girl from a poor family to live with a disabled man. Next slide, please. This slide shows that the girls from childhood live with mental trauma and fear that stays with us throughout our lives. We are blamed and beaten, no matter what is the context is. Next slide, please. Care during pregnancy is very difficult. No free treatment in private hospitals and no facility in government hospitals. All my friends underwent cesarean section. Don't know why. Families continue with rituals. Next slide, please. Life become more difficult after operation and disability. Next slide. Self-care is the only way for us to fight the dual stigma that we are living with. After joining Help Life, I realized that we can empower girls with disability by creating awareness and supporting and building their capacity in many ways, providing higher education, vocational training, wellness and life skill program, and overall personality development. Help Life has empowered 45 girls with disability. They are now economically independent, have a voice, and bringing in the required change. We now have Jagaram platform that brings people with disability from all over India to interact and make sure that their voice is heard. We still have a long way to go. Next slide. At Help Life, we have many activities that empower girls to take good care of themselves. We have many income generation activities so that girl can earn their own living while also getting support from Help Life. Next slide. You can see girls being trained to become self-reliant. Next slide, please. Exposure visit. New Generation Service Exchange Program at Brazil through Rotary Club. Wellness program at Help Life. Prayers, meditation, yoga in disability. Life skill program for character building. Sex education or sexual health. Public speaking at various forums. Jagaran platform at Help Life is responsible for old and new students for open interaction, newspaper reading, working as receptionists, posted at corporates, and foundations as interns. Working at Help Life. Girls doing well in education are given preferences at Help Life for employment and salaries paid at double from the market rate. Work as great empowerment tool for the differently abled girl. Encouraging hobby for development, musical instruments, singing, dancing, debates, swimming. Next slide, please. You can see girls being encouraged to take charge to their lives. Next slide, please. Lastly, I want to say that Help Life is a not program, but a movement as we keep empowering girls every day. And there are many volunteers joining Help Life to realize our dreams of being respected in the society and have a voice. But we have a long way to go. Next slide. Thank you for giving me the opportunity and your attention. Thank you so much.
Thank you so much, Bhavana, for the presentation and for explaining some of the challenges that girls with disabilities are experiencing, as well as the importance of self-care. So I encourage people to hold your questions. Feel free to drop them in the chat, make note of them so we can discuss any questions for Bhavana after the next two presenters. We are running a little bit behind schedule, but I believe that we will finish on time. So I want to go ahead and introduce our next presenter, Tandu Tangla. She's the program coordinator at Beyond Zero. Tandu was born in a small town in Eastern Cape, South Africa, and graduated from a 2-year course as a pharmacist assistant in 2011. She then worked in both public and private hospital pharmacies and a retail pharmacy. Tandu worked as a clinical researcher at the University of Free State in South Africa and is currently a second-year student at the University of South Africa working on a Bachelor of Arts in Public Administration and Communication Facilitation. So Tandu will share a bit more about the challenges facing the transgender community in accessing respectful care and how community collective care and self-care plays a role in their healthcare. Tandu, take it away.
Good afternoon, colleagues. I hope we are all well. I am going to show my face for a second and vanish again because I'm in the office. Good afternoon again, and thank you for having me. Yep. Can we start with slide 3, if possible? This should be slide 4. 3, please. Thank you very much. The outline of this presentation will be looking at introducing you, colleagues, to the company that I work for, Beyond Zero. And obviously the disclaimer, just to set the tone in terms of the definition of terminologies in this session, the overview itself, what are we covering in this session, defining the healthcare system, the roles, the purpose, and the function, looking at the health challenges and what is expected of women and providers to be doing whilst the healthcare system is under pressure and under-resourced. Can we go to slide number 2? Beyond Zero is a Section 21 NPO, locally registered in South Africa. It is headquartered in East London, Eastern Cape Province. It has also other 3 offices in different provinces, one in the province of Free State. We also have another office in the province of Limpopo and the 3rd one in Gauteng Province. The organization works with communities, provincial governments, civil society organizations, AIDS councils, health facilities, and academic institutions to improve health systems and health outcomes of people in the communities it services. Next slide, please. The current research shows that there is a high burden imposed onto the health system, particularly at this day and age. Looking at the COVID-19 pandemic, what it is doing in the entire world, and also not forgetting HIV, tuberculosis, and STIs in our populations. The focus of this session, therefore, it focuses mainly on health rather than illness and prevention rather than cure for adolescent girls and young women, and also women in general settings. This means that whatever it is that we are going to be doing in this program, it promotes healthy living lifestyles. It also prevents people to be found in health facilities where they are going to be having challenges because it is under-resourced It also, it does not have sufficient funds to cater for women needs or AGYWs. Next slide, please. For the content of this session and its discussions, perhaps we need to define the health system. What does it mean to answer the question above for this session? Health system, it is a set of components that supports and improves the health of the population. In the Republic of South Africa, public health system is funded by the government and it is open for everybody for service consumption. It would be unfair if perhaps we could leave out the private sector, though the content of this session focuses mainly on the public healthcare system. But again, we need to remember that when we are talking of the healthcare system, we are talking both the public and private sector. Private sector, it is supported by those people who can afford to contribute towards medical aid, since it benefits mainly from those schemes. And it is said that in this day and age in South Africa, only 20% of the population can afford to make such contributions towards medical aid for their healthcare. And the rest is covered by healthcare system. That already can tell that there is a lot that the healthcare system has to offer and also has to attend to in terms of the availability of the clinicians on the ground, and also the ratio of the population in relation to the number of clinicians available, and also the healthcare facilities. Next slide, please. The purpose of the healthcare system, it is to provide simple logical services to ensure that services are coordinated and linked together so that people can be treated in the most convenient way. For instance, if I were today to be coming into the health facility and I am coming for my HIV medication, if there is a need to be screened for tuberculosis, it would not be ideal for me to be sent from pillar to post, but rather to get all the services packaged into one space, so that when I leave that particular clinician, I go straight home without missing any other interventions that are provided in the health center. It is to ensure that recipients of healthcare are involved in designing the services that will be that they will be receiving. This is talking to the analysis on the back on the spaces where one would be contemplating to establish healthcare facility. Then one would have to have consultations with the communities they are serving to look at what is prevalent in terms of the challenges and healthcare issues in that particular community, so that one is able, therefore, to build what is necessary and what is going to be delivered according to the needs of that particular population in the given space. Next slide, please. Functions in the Republic of South Africa, they to give comprehensive and integrated services up to including district hospitals, decentralized management of services delivered at district hospitals, address needs for effective referral mechanism within and between districts and all other levels of care, deliver care in the most efficient, effective manner possible. In the nutshell, this means that delivery of healthcare should not be given based on what westernized interventions entail, but rather it looks to look at what are the people's beliefs, their cultural backgrounds, so that the services are then rendered with what the people believes in terms of culture. Next slide, please. The challenges of the healthcare system, it is actually the opposite of the previous slide, where we would be talking of comprehensive intervention. What would be then the comprehensiveness of healthcare interventions if we are excluding the traditional ways of promoting and maintaining health? So if we're talking comprehension, therefore we need to include the traditional healers, which forms part of our society and civil society as well. In 1999, in South Africa, there were estimated between 150,000 to 200,000 traditional healers. Part of the services that they offer, it is divination, the herbal cures, and as birth attendants. This can be a crucial role played by the traditional healers in building, strengthening health systems for women's sector and all other or general population, in fact. Next slide, please. The healthcare system needs to integrate or put together all the services that are being offered into one box or package it well to address all the needs as a holistic approach for our target groups. The referral pathway should be established as well between both parties that will be talking to the governance of the programs so that they are not all over, and as well as the traditional way of doing things does not oppose what westernized medicine is supposed to be doing, but are rather working together in helping the clientele. Next slide, please. What do we then do until the necessary structural systemic issues in health service, which hinders self-care and respectful care are changed? The first and foremost, perhaps I can say, it is to create safe spaces for meetings and discussions. Once we do that, because today we are talking of more love and more global lens, then we need to mobilize other peers who are in the same predicament, or rather in the same age as our target groups, and also allies, because the education that is provided in those spaces, it will require more people and more allies. So it is very important to mobilize allies so that we join forces with them in sharing lived experiences that will be talking to generating knowledge of what our people are facing in our communities and be able to take it forward. Identify champions within that space to reach and educate target groups about self-care. Once we are on that stage, then we would have reached what it is called expected results. Then, therefore, we can be in a position to establish advocacy, because obviously we would know expected advocacy results by now for self-care and dialogues. Funding, again, colleagues, is very important to develop skills of the people that we are serving, to liberate them from poverty and dependency. There are skills such as fashion designs, nail arts, knitting, and a lot of others. Next slide, please. The providers need to engage the women's sector on collaboration with other existing stakeholders and establishing steering committee for governance. In my 1-minute experience of working in a public sector and NGO, collaboration is very important. Currently, I'm working as a transgender program coordinator on HIV prevention program. It would have not been possible for me to achieve large numbers in response to the program if I were not collaborating with existing stakeholders in the areas where we are implementing the program. So that's very important. Create demand by IEC material or community radio talks so that we'll reach out to people as much high numbers as possible. Provide education on human rights violations, identification and recording such, and also reporting and referrals for intervention. This is very close to my heart because many a times where we find our key and vulnerable populations, being victimized in terms of their gender, in terms of their chosen lifestyle, in terms of what they require from the service providers. So it is important that we educate them on human rights. This will also help them to be able to come out and report human violations, provide ongoing psychosocial services and to eligible clients, develop reporting tools, provide financial assistance to execute self-care program. Next slide, please. Thank you very much, colleagues. Thank you.
Thank you so much, Tandu, for that presentation. We're going to go right into our next and final presenter for the day so that we can have a little bit of time for Q&A. Wanjiru Kihusa, the founder and CEO of the organization Still a Mom in Kenya, will be our next presenter. Still a Mom is an organization that has supported over 5,000 parents in Africa who have gone through a miscarriage, stillbirth, or infant death experience. Ms. Wanjiru's career in bereavement support and advocacy spans 7 years, and she is passionate about improving the support offered to grieving mothers and fathers in hospitals, and the benefits that arise when society rallies around those parents who have lost a child. So we will hear from Wanjiru. Please go ahead when you're ready.
All right. Hi, everyone. I hope you can hear me. Can you? All right. So good evening. I see it's morning for some. It is afternoon in South Africa, and it is evening in Dubai. So I currently live in Dubai, but I'm originally from Kenya, and I will be sharing what self-care looks like from somebody who has lost a baby. So kindly, let's go to the next slide. So just a reminder of what the guiding questions have been, is that what can women do in the meantime until structural issues in the health systems are changed to better enable respectful care, and also the providers. And number 2, what does shifting power in the healthcare system truly entail? Next slide, please. So there was an image somewhere there, maybe in slide 2, maybe we missed it. Oh, okay. Anyway, so basically there was the presentation I have on my end has an image, but it's okay. So basically, I run an organization called Still a Mom that supports parents who have lost a baby. And I did lose my daughter in 2013 to an early miscarriage, and I have had a late miscarriage also. And basically, I have been on the receiving end of, I would say, the lack of care or respectful care that comes additionally when there's bereavement, when there's a death. And while none of us anticipates that the childbirth process will come with it, bad news, sometimes it does. Sometimes the way we expect things to go doesn't go that way. And so during pregnancy, there might be a miscarriage. During the birth period, there might be the bad news where you're told, I'm really sorry, but there is no heartbeat. So, and sometimes, you know, when we think about the entire perinatal duration, even a couple of days after delivery, there could also be newborn deaths. There are issues like SIDS. So basically, when we think about respectful care for people who have lost a baby, what exactly does that entail? And what can women do? The next slide, kindly. So bereaved parents can self-advocate and speak on behalf of others. And this is one of the biggest things we have been doing with healthcare providers, just to train them that your patients have a voice. They have a voice, they can speak to you, they can speak to what their needs are. And when you think about compassion, because we use that word a lot at the beginning of this forum, what does compassion look like when somebody has lost a baby? If ever there was a time to be respectful, to be compassionate, to provide information. And the issue of the right to information is a very important thing here. I have met and worked with so many parents whose biggest complaint was nobody told me anything. All that happened is somebody came in next to my bed and just started to plug in stuff, and maybe I was going to be induced, but nobody explained what the next steps are. And small things that we imagine are really small, like moving somebody from the labor ward into the regular ward where they do not have to go to bed listening to people's babies crying and her baby did not making, small things that do not necessarily require money and personnel, any additional funding to the hospital. We don't need extra midwives for that, because sometimes when we get to a place where we are recommending certain changes, everybody's like, whoa, that costs a lot of money, that requires XYZ. Not necessarily. A lot of it is just moving around a bit of the bureaucracy that comes with this process and just seeing what can you do as the person who is on shift that night or who is around at that time, what decisions can you make? And we have come across hospitals that begin a bereavement room, and it was probably just a store that was cleaned out. It had a window, a baby cot was put there, and it doesn't even have to be a super comfortable couch. It could just be even be just a formal place they can sit. But this is a place for parents to come and hang out with their child, including a baby that was well delivered, clean, dressed, wrapped, and presented to their parents so that they can have some time with their baby. So some of these things do not require that we move mountains, but they are a huge influence of the bereavement process for these parents. And the realization that healthcare workers are the first, you are the contact point for these people. Whenever they think about this horrible thing that happened to them, you will be the person that they remember first. So if the care you gave was compassionate and kind, that's what they're going to remember. And I have worked with parents for the last 8 years, and majority will admit that it was on negligence. They know the doctors and the healthcare workers did their very best to save their child. But it's usually those small things that we don't deem necessary or important, like saying, I am terribly sorry for your loss, or would you like to spend some time with your baby? Or if they actually ask for it, instead of going like, why would you want to see a dead child? You need them to recalibrate your mind to see them as people who have walked the pregnancy journey and just need to spend some time with their baby. So bereaved parents can self-advocate, and we need to get in the habit of hearing their voices. Additionally, if we provide information, because a lot of these situations happen emergency, nobody imagines that they will go to the hospital and not deliver a stillborn baby. So they do not know what their responses are. But if you provide correct information, then they know how to respond. For instance, if they know that after surgery, if you want to see your baby, that's an option, then they begin to think about it. And by the time you offer it, they're comfortable with the idea. So yes, so parent voices should be an integral part of any systemic changes or any interventions, any changes that we see in healthcare policy. Parent voices should be a very integral part, because after all, next slide, please. Okay, it seems that I have a different, anyway, but the next slide on my end was supposed to be that why parent voices are a very integral part is because healthcare is extremely customer centric. Sometimes we don't see it as such, but if ever there was a field that is customer centric, it is the healthcare industry. And so what happens is that it is very important for providers to center parent voices in the pregnancy and childbirth initiatives, because it is an extremely customer-centric profession. Additionally, during and immediately after a child loss event, the healthcare workers' guidance is crucial. And of course, that compassion trumps all. Now, the care for the caregiver is something that has been extremely, it's an extremely crucial issue, because we have worked, when we originally began, is we would go to healthcare workers and we would train them on how to support a parent who loses a baby. And then we started to realize what a big effect it has when a baby dies on your watch, when you were the one in the team delivering that baby. So what does that do to your mind and your mental state? And so we began to have to do, counseling sessions for the healthcare workers themselves, and understanding, do they have even some form of peer support internally in the hospital? So care for the caregivers then becomes a very crucial an element of self-care and respectful maternal care. So because it's a whole concept of we cannot pour from an empty cup. These people are consistently coming today, tomorrow, the day after. And yesterday a baby died, but today you're expected to continue as if nothing happened, and And while some of the death situations are actually very mellow and it could be like intrauterine fetal death, some of these situations that a baby is born and there's need for resuscitation, like it's a very mentally intense procedure for the people that are working in the hospital. And if their mental well-being is not catered to, we can then not come back and be surprised that they seem to be far removed from the reality. We cannot come and say, oh, he treated me like I'm just another statistic. But that's their coping mechanism, because they're trying not to carry their work home because they're really, really heavy burden. So this is sort of like a double-edged sword. We are training healthcare workers to be more compassionate, more caring, more present in the immediate situation, but also asking ourselves, how can they do that when their own mental well-being is not being catered to? And so it has to be that when we're thinking of self-care, we're thinking about both sides of the coin. And my last slide actually is on the part of shifting power, is when we come at healthcare from a customer-centric angle, then a lot of things make sense, because when you think about you as a banking client and how the kind of care and support you expect from your bank or your internet provider, there's a way you feel entitled to a certain level of service as the client. And if you're not getting it, it catches you off by surprise. But when we look at healthcare as a field, we sort of feel like it's a favor, it's a kindness, but the truth is it's extremely customer centric. And so we have to consistently center parent voices. What do they want? Now, a big part of what Still a Mom has been about in Kenya and in a couple of African countries has been to bring in respectful bereavement care as part of the respectful maternal care. And this has been, this progress, and this is good, but sometimes, of course, systems take forever. And when we think about even like issues like anything that consists as trauma, the birth trauma, postpartum depression, all these conditions that come with the childbirth process that do not necessarily go as planned, then we have to imagine that patient needs have to be the guide. It could even just mean that on that 6-week visit, when that person comes back, that patient comes back to be checked, what are the follow-up questions that can go, as opposed to just, how are you? What's your mental well-being? Like if their baby made it, and you're trying to understand whether there was breastfeeding or how has that been going, if they had a CS scar that you need to inspect, but also going a little bit above and beyond and finding out regarding postpartum depression. The same can be said about subsequent pregnancies. I have seen, because I have had the same doctor when I was pregnant with my now son, because she knew I had previous history of child loss, then there is a different way that there's a different way I was cared for, because you become a bit of a higher risk patient. And so when I said I am feeling XYZ, or today the baby did not kick as much, then I am given a little bit more attention, because she knows where I'm coming from. And so things are, we tend to be taken more seriously if somebody also has history of where we're coming from as high risk patients. But that should not just be the case. It should be for every mother. If they say that this is the way they are feeling, then that should be taken seriously. And next slide. Yes, I suspect that this was at the end of my presentation, but my most recent presentation had an image that also says that it takes a village to raise a child, but it also takes a village to raise a mom. And so basically what we are saying here is that all of us are integral factors in the, raising the children, but making the pregnancy, childbirth, going home, that entire period of a woman's life to be as pleasant and as trauma-free as possible, and ensuring that their well-being then is consistently looked after. Thank you very much.
Thank you so much, Wanjiru, for that presentation. Very interesting perspectives from the last three presenters on what it takes to care for and provide respectful care for these populations. So for folks, we're at time, so I understand if people have to hop off. I do want to respect the presenters' time and give folks the opportunity to ask them questions and connect with them more deeply. So, you know, if anyone can stay over 2 to 3 minutes, you know, please do. Is there a question from the audience for Wanjiru, Bhavana, or Tandu? Feel free to just come off mute if you do have a question. I'm going to pause for another 10 seconds. Okay, any final comments from the last three presenters that you want to share that you didn't get to share in your presentation?
Hi, Alice.
Yes, please go ahead.
Thank you very much. For me, there isn't any comments from my presentation, but actually to thank everyone for listening to me while I was talking, and thank you for being given the platform to talk today. Truly appreciate it. Thank you.
Thank you so much. Bhavana or Wanjiru, any closing thoughts?
No, thank you.
Okay, so thank you everyone for attending today's discussion. I hope you learned a lot, took a lot from this, and are able to implement some of the lessons learned in your own practice, wherever that may be, in a nonprofit, in healthcare, in policy. You can continue this discussion tomorrow with the final part of the series, and also in the Discover Self-Care community, which the link was just shared on how you can join the discussion thread. And there's also a survey and evaluation to complete about today's session, where you can provide feedback. So please do click those two links and follow up via the evaluation and in the community space. So thank you all, and they'll see you tomorrow.
Please be sure to complete our session evaluation form to provide feedback on today's session. I will put the link to do so in the chat. Thank you.
Thank you, everyone. Bye.
Bye.